can I have that for a second? Thanks. All right, so now for real, we're going to introduce our next speaker, Dr. Mark Schutta, who is a G. Clayton Kyle Associate Professor of Diabetes, Medical Director of Penn Rodenbach Diabetes Center for the Hospital of the University of Pennsylvania and the Perelman Center for Advanced Medicine. Doctor.
Great. Well, thanks for having me. Can you guys hear me all right? Okay. So I don't know if I'm going to stand up there or come down. I think I prefer actually to be down here, but you can see me. So, and where is the slide advance thing? I need that. Okay. So I'm really excited to talk to you guys, and it's funny, when I first started as director of the center, I used to think, well, I need to see all the patients in the Penn healthcare system and all the diabetics in Philadelphia because we know what we're doing. But I've realized that because of this epidemic that we have, there's no way that I can do that. And I have 8 colleagues, endocrinologists, who see patients with me. And we have a big staff of people. That's a lot different than what you guys are dealing with every day. And so I kind of have realized that my job is to educate my colleagues in primary care, family practice, et cetera, in how to take care of diabetic patients. So what I'm going to do is I'm going to try, and I've been sort of charged with the task. Oh, these are my disclosures. My wife is a medical director at Merck Pharmaceuticals, and these are the learning objectives, and this is sort of what I've been charged with, to review and explain how the ADA, JNC8, and AHA guidelines influence the treatment of diabetes, to identify barriers to guideline implementation, and identify new strategies to implement guideline-based screening, treatment, and management. I'm going to do that with a series of cases, okay? And please feel free, if you want, to ask any questions as we go along. But let's start with the causes of death in people with diabetes, right? So this is why we're all concerned about diabetics. And you can see on the left-hand side, the number one cause is ischemic heart disease. And it's, outweighs everything else dramatically, right? So this is why it's so important for us to address blood pressure, dyslipidemia, et cetera, and prevent this. And the good news is that we have more patients with diabetes. Our obesity epidemic has sort of plateaued, and our ability to intervene with patients and extend life has improved dramatically in patients with type 2 diabetes. Now, if you look at A1C concentration as a predictor of mortality, this is what you see. So if you ask yourself the question, well, 5.5 is a pretty good A1C, 6.9, not so good, but you can still see as, the A1C starts to increase, the incidence and of mortality, cardiovascular death, and all-cause death starts to increase. So when I'm asked by people, well, what's your goal for an A1C for me? And the ADA recommendation, which we'll talk about, is less than 7%. And I tell people, particularly when they're new onset type 2 diabetics, my goal is normalizing your A1C. My goal is to put you into remission from your diabetes. Because if you fractured your leg and you went to an orthopedist, would you say, you know what, just put a cast on this. If it heals 70%, you can take the cast off and I'm okay with that. Nobody would do that, right? So why should we do it with diabetes? But the truth is, we're challenged with lots of patients who are very insulin resistant, and you guys are looking at people who have A1Cs greater than 9%. I have lots of those patients as well. Those are the really challenging ones. So this is a schematic that I put together based on the UK PDS diabetes study that came out in 1995, and it looks at the progressive beta dysfunction in overweight diabetics. And when I see new patients, I draw this out for them in the room, and I show it to their family members, because this is really important because it explains a little bit of the pathophysiology. So you can see on the y-axis you have beta cells and the percent of beta cells, and on the x-axis you have years from diagnosis. And you can see that starts down here, halfway along this curve, right? So that means that for 12 years, these people have been having problems with their blood sugars, and they're often in a pre-diabetic state. So we all know that there's age-related beta loss, right? So as you age, you start to lose beta cells, and that's why age is a risk factor for type 2 diabetes. But when you're someone who is prone to diabetes and you have a genetic predisposition, you're on this trajectory here that really spans over roughly 24 years of time. Here are the pre-diabetic patients, here are the people who are diagnosed with diabetes. So at the time that you're diagnosed with type 2 diabetes, you've already lost nearly 50% of your beta cells. And that's a big problem because you need those to secrete insulin, okay? And if you get to the point where you're down to 25% of your beta cells, and that's maybe 8 years since your diagnosis, at that point you don't secrete enough endogenous insulin for a lot of the oral drugs to work, And that's at the point that you need basal bolus insulin. So those are what we used to call insulin-requiring diabetes, right? And so I show patients this and I tell them, look, what we're trying to do is shift this curve upwards, or another way to look at it is to go back up the curve. And it turns out that beta cells are plastic cells that can regrow, and it takes a while. It'll take like 5 years or so to do it, but if patients lose weight and exercise more, they can do this and slow the progression of the disease. That's why this is so important. And we know from data from the diabetes prevention program, losing 7%, 8% of your weight is generally enough to do it. Does anybody have any questions about this? The other thing I wanted to point out is when patients present with polyuria, polydipsia, high blood sugars, and they're diagnosed with type 2 diabetes for the first time, 50% of them already have microvascular and macrovascular complications of the disease, right? So we really want to capture patients in that pre-diabetes state. So here's a case of diabetes prevention. This is a 64-year-old woman with a strong family history of type 2 diabetes, and these are her labs: fasting glucose of 92, an A1C of 5.9, LDL 104, HDL 54, TSH is fine. The next year her LDL is going up, her A1C is going up, and her fasting glucose is also going up to 105. She started Weight Watchers in August, and she's frustrated that she's not losing weight. Anybody have any patients like that? I have lots of them, right? Diet and exercise history. She restricts her sugar and carbohydrates. And people tell you that, but then when you really ask them, oh, really, a bagel's, I didn't know I couldn't eat a bagel. And I always tell patients, a bagel is a disguised bag of M&Ms. That's all it is. Remember that. Meal times, 3 times a day, bars for meals, eats out every night. That's a big problem, right? Chicken salad, sometimes half a baked potato, drinks 0 ounces of juice per day, which is good. So that's a question that we ask all our patients. So this is basically coming right from my EMR new patient visit. These are the questions that I ask patients. Eats 3 pieces of fruit per day. Exercise 3 to 4 days per week of Bowflex and has lost inches. Now, you guys are getting an apple at the end of the day. I'm known at Penn as the apple doctor. Why? The security guards have given me that name because every time I walk out the door at the end of the day, I'm eating an apple. I bring one to work every day and I always have one. And Bob said this, and it's absolutely right. Apples are a low glycemic index fruit. They're great for diabetic patients. Why? Because there's skin on an apple. When you consume the skin on any piece of fruit, excluding grapes, you are delaying the absorption of the sugars in the apple, right? And that's because of the protein that's in the skin of the apple, right? That's really, really important. And the other thing we always tell our patients is eat 3 meals a day and try not to eat snacks in between your meals. Eat the piece of fruit with the meal. All right, so this is her actual weight loss after I saw her for the first time. Look at that. She lost 22 pounds or 12% of her body weight. And when I saw this and I looked at this graphic, I was just stunned, right? And I said, how did you do it? She said, well, it's something you said to me, Dr. Schutta. And I said, well, I'm all ears. Tell me what I said, because I don't remember. And she said, you told me that if I eat a Snickers bar for breakfast, lunch, and dinner, I will lose weight. And I said, that's right, I told you that, but remember I told you not to do that, you know? And she said, that's right, but the point I learned from that is it's about calories, right, and reducing calories. Now we know now that all calories are not created equal, and calories that have a lot of sugar in them are definitely worse for us, particularly for diabetics, but she started measuring her calories, and that really made a big difference for her. So she increased her exercise to 6 to 7 days per week for 45 minutes per day. Now she's not just doing the Bowflex, she's doing aerobic activity as well. She's got modified her diet, so oatmeal and berries for breakfast now, soup and salad for lunch, low-calorie frozen entrees and piece of fruit for dinner, and no limit on her veggies, right? Our fruits and veggies should be about 40% of our diet, right? 1 dessert per week. She's no longer going out to dinner every night with her husband, who, by the way, is also a patient of mine, and he's a whole different story. And she snitches on him all the time. It's great. So her A1C is now 5.7. Her fasting glucose is 84. Wonderful, right? So she's done fantastically well. Now, here's the challenge. We tell patients to exercise. I had just stepped out of a meeting on non-surgical methods of weight loss. I walked into the hallway at the Endo Society meeting in 2014, and this is what I saw. My fellow endocrinologists not using the stairs, right? That's a big problem. You know, when I got here today, they said, oh, yeah, take the elevator up 3 flights, blah, blah, blah. And then I needed to use the bathroom. And I realized there were stairs here that I could have taken. But nobody told me to use the stairs, right? I also have a Fitbit that I wear with me all the time. And I'm in constant competition with my son, who's 10 years old, regarding steps for the day, and he kills me every time, right? So yesterday, I had 11,000 steps, and I said, Ben, I got you. And he goes, I don't know, Dad, I don't think so. What? And I said, Ben, how many do you have? 18,000, right? Well, what'd you do? He just went to school. That's all he did. And it's a teaching moment for me, right? When you were a kid and you were running around, even when you were a college student, you were so much more active than you are now. So we need to kind of recreate that. So I really recommend Fitbits, Jawbones, Pacer apps on phones, whatever you can get. And I tell patients 10,000 steps is not the magic number. It can't be because it's got lots of zeros at the end of it. Therefore, it can't be a scientific number, right? It's impossible. Somebody made it up out of thin air, okay? So I tell patients, do a week of steps, see what you're doing, and then just try to double that. And then after that, maybe you can increase that as well. All right, so that's the problem. Why exercise matters in type 2 diabetics. Now, this is the actual pathophysiology behind this, right? So if you look down there, we're looking at day one. If you take a biopsy of somebody's muscle who hasn't exercised and you measure GLUT4 transporter, I don't know if you guys know what GLUT4 transporter is. It was cloned by a guy at Penn named Maury Birnbaum, and it's the singular most important protein for transporting glucose into muscle and fat cells and liver cells. GLUT4 transporter is the protein that is increased when you treat patients with thiazolidinedione drugs like Actos, Avandia, et cetera, right? And it does that by going to the nucleus and increasing transcription of messenger RNA. And this is what happens when you exercise. So if you look at the GLUT4 transporter concentration and it's X, and then 7 days of moderate exercise for 60 minutes duration, and then you recheck the muscle biopsy, it's 2X, right, double. And that's actually more than any thiazolidinedione drug could do for you. And it's not a drug that's causing potentially bladder cancer and weight gain, which the thiazolidinediones do in spades. And the thing about this, don't tell your patients this part, this effect lasts for about a week or two, right? Don't tell them that because then they're just going to exercise and take a week off. But it's really important. Now, modest weight loss reduces the incidence of new onset diabetes. This is the data that I'm sure a lot of you have seen from the Diabetes Prevention Program. And it shows us if you take a group of people who are prone to getting diabetes, who are pre-diabetic, and you compare placebo, metformin, which was 850 milligrams twice a day, versus lifestyle, lifestyle does the best. And the relative risk reduction is 58%. And these people didn't do a lot. They exercised brisk walking for 150 minutes a week, and they lost about 7% of their weight. So that's what you want to do when you see patients who have prediabetes. Now, in 2012, there are 86 million Americans who had prediabetes age 20 and older, and that's increased from 2010, where we were at 79 million. Less than 8% of US adults with prediabetes are aware of their condition. So it's really important for all of you guys to look at patients who are predisposed and make sure that you screen them, and we'll go over that. The 5-year conversion rate from prediabetes to type 2 diabetes ranges from 10 to 20.